Today at the ASCO annual meeting, Dr. Sznol presented the data of a study with a combination immunotherapy with ipilimumab and nivolumab in patients with advanced melanoma. Could you explain the study design and tell something about which patients participated?
These were all patients with metastatic melanoma. Some of them had had prior treatment, about 50% did not. The study was designed as a phase 1 trial in which we kept the dose of ipilimumab initially fixed at 3 milligrams per kilogram, and we escalated the dose of nivolumab from 0.3 milligrams per kilogram to 3 milligrams per kilogram. And then once we were done with that dose escalation, we actually flipped and gave ipilimumab at 1 milligram per kilogram and nivolumab at 3 milligrams per kilogram. The combination was given together every 3 weeks for up to 4 doses, and then there were 2 different schedules after that. One in which anti-PD-1 nivolumab was given alone every 3 weeks for 4 doses, and then the combination every 12 weeks, and then a second schedule which was done later in the trial in which nivolumab was given 3 milligrams per kilogram every 2 weeks for up to 2 years.
How long is the follow-up currently, and what were the results at that time?
For the first 53 patients, the follow-up is at least 1 year and extending out to almost 3 years.
Could you describe the responses and the duration of these responses seen in the study?
The overall response rate, objective response rate, was 40%, and there were probably another 25% of patients that had unconventional responses. But among the patients who had objective responses, the vast majority are still ongoing. They're very durable. The median duration has not been reached yet.
And did you see similar effects in all the subgroups?
As a matter of fact, yes, we saw similar activity in patients that had BRAF mutations or were wild type for BRAF. And the very interesting thing is that the activity was very similar in patients who had tumors without PD-Ligand-1 expression at baseline versus those that did. It's very significant that we saw activity in patients who had very little PD-Ligand-1 expression at baseline, because in that group we would have expected a low rate of activity with nivolumab and perhaps with ipilimumab alone. But the combination had very similar activity in that group compared to PD-Ligand-1 positive, and that really suggests that the combination is acting in a synergistic way.
What do the results tell about the toxicity of the combination treatment?
The overall toxicity of the combination was more than what you would expect with either single agent. Overall, the rate of grade 3-4 adverse events was in the range of 60%. Now that sounds very high, but it turns out that many of these adverse events were laboratory abnormalities which could be managed by standard algorithms that we've developed. And even the toxicities that we did see that were more serious, that were more like ipilimumab, were again mostly managed with algorithms that were developed for ipilimumab. So the rate of toxicity was high. In fact, many patients had more than one adverse event. However, we learned how to manage it, and I think the activity more than made up for the toxicity that we saw in this combination.
Where should future studies in this field focus on?
Well, I believe if this data are confirmed in phase 3 trials that ipilimumab nivolumab will be the standard of care, at least for a while. But there will be other combinations, so we'll want to look at other checkpoint inhibitors. And we'll also want to examine checkpoint inhibitors together with co-stimulatory agents. And I think those 2 combinations, combination of checkpoint inhibitors or co-stimulatory agents with antagonists of checkpoints, will give us another level of improvement of activity. And there's other very interesting combinations together, for example, with adoptive cell therapy. So there's an infinite number of combinations. I do think that we'll be able to improve the activity, and if we get very smart, we might actually be able to improve the tolerability of this regimen.
Thank you.
Thank you very much. Thank you.